All right, good morning, everyone. I think we'll go ahead and get started so we can make the most of our hour here with all of our panelists. My name is Elizabeth Miranda. I'm one of the research fellows at the Harvard program in global surgery and social change. And together with Incision and the World Medical Association, we're very excited to welcome all of you today to our panel highlighting youth in global surgery. So we're going to hear from some really amazing leaders in global surgery and the work that they're doing and how you can get involved and help that out. So our panel today is going to be moderated by two of the people you see here. So the first is Dr. Micheline Dreza. She's an obstetrics and gynecology resident in Poland and has a special focus on sexual and reproductive health and engagement of the youth in global health spaces. She's been involved in a large number of organizations and held leadership roles, including in organizations like the International Federal Medical Student Association. She's worked with the Human Reproduction Team at the WHO and the Department of Reproductive Health Research, as well as the newly launched WHO Consolidated Guideline on Self-Care Interventions for Sexual and Reproductive Health Research. She's also pursuing, on top of all of that, her PhD in obstetrics and gynecology. And then our second moderator today, I've had the pleasure of working with at PGSSC, is Jean Wilgens Lartigue. Is a 6th-year medical student at the State University of Haiti, an aspiring neurosurgeon, and did some amazing work during his time here, but just beyond that as well, he's the former vice president of the Haitian Medical Student Association, current chair of Incision Haiti, and then also serves as the secretary for the Global Neurosurgery Committee at the World Federation of Neurosurgical Societies. So thank them so much for being here, for helping guide this discussion today. And I also want to introduce Manon Pijolet, who's also helped us, and she's a fellow as well at PGSSC and has worked to put this together as well.
Good morning, everyone. So thank you, Elizabeth, for giving me the floor. I'm Manon Pijolet. I'm one of the junior fellows at the PGSSC and also the chair of the Global Surgery Working Group at the World Medical Association Juniors Doctor Network. And I would especially like to thank Boris Cespedes, the consul and commercial attaché of the Embassy of Bolivia in Uruguay, to take the time out of his very busy agenda to join us today for this session. Thank you very much for that. And with this, I have the pleasure to open the floor for Wilgens and Micheline to start off the event.
Thank you so much, Manon. And we have a very tough task with Wilgens to lead this incredible panel. So a few housekeeping rules. I know that there are a lot of people on the line. It's great to see that we have so many attendees. So if anyone has a question to our panelists, please tap it down in the Q&A section that you have in the on the down of your screen. So please feel free to do that. And yeah, let's get it started because we have a very packed agenda, but also please know that this is a discussion rather than a presentation mode. So it's a great, great moment to interact with our amazing panelists. Let's kickstart that. I want to start with introducing our panelists, and I'm going to start with Dr. Hassan Ali Daoud, who is an activist fighting for a social change. Hassan has a great passion for improving the healthcare of his country, Somaliland. He founded and led several organizations, including Incision Somaliland, Youth for Health, Somaliland Federation of Medical Students Association. He graduated from Mahmoud Medical School and is a doctor in Hargeisa Group Hospital. He's currently a member of Incision International Team and International Association of Student Surgical Society, and an avid campaigner for global surgery and health for all in Somaliland. So, Dr. Hassan, we want to start with a question that got us all here. So what is your story and what got you interested in global surgery? We are all ears for that.
Thank you so much, Micheline, for a nice introduction. My global surgery story came up when I have tried to volunteer at a fistula hospital in Somaliland where 400 women were coming every 6 months to have surgical repair. And as a medical student, I was going there to write down the history of the patients and how the incident has happened to them. So they used to share very shocking stories that all of those mothers, they have in common. They were malnutrition. Some of them have been married as a child marriage, and the main cause was obstructed labor. And some of them were telling that the head of the baby was coming out and they didn't have skilled healthcare worker that helped them deliver. So I saw that huge problem as a young medical student, and I was very shocked at that time. As soon as I started the maternity ward in my rotations, started my clinical studies, I saw again I've lost two mothers due to bleeding, antepartum hemorrhage and postpartum hemorrhage. And the hospital was a regional hospital and it didn't have a blood bank facility at that time. So we tried to find out a donor at that time, but we couldn't find. We were waiting for the first case. We were waiting someone to arrive like almost 30 minutes, and we lost the first case. And within 1 week again, we lost another mother. So I tried to fundraise, and alhamdulillah, we found people who supported us, and we raised a money of $10,000 that established a blood bank facility at Borno Regional Hospital, which now serves for that region. So that was my first story where I had the opportunity to intervene in the surgical system of Somaliland.
Thank you so much, Hassan. Super inspiring. Wilkins, would you like to introduce our next panelist?
Sure. Our next panelist, I'm introducing Barnabas. Dr. Barnabas Ariante is actually full pharmaceutical surgery research fellow at the PGSC at Harvard Medical School and Boston Children's Hospital. He's a general surgery senior registrar of the West African College of Surgeons, and he trained at the Jos University Teaching Hospital. He is a surgeon with the National Postgraduate Medical College of Nigeria. He has had experience at the WHO Collaborating Center for Community-Based Experience and Service, and has worked in many sparse resource contexts with various volunteer surgical activity. He advocates for local improvisation and contextualized surgery in low-resource African settings. His research interests are focused on surgical improvisation and filling gaps in health management. So Dr. Barnabas Ariante, it's a pleasure to have you with us today. So
thank you so much.
Yes, one question is, you've been working in resource limited settings. So what has been some of the biggest challenge in your global surgery career, and how have you addressed it and managed to overcome it?
So there are so many challenges that we see in the global surgery sphere. The first, I believe, is the disease burden. Globally, more than 5 billion people no access to care. And you know that 90% of those people in low-income countries cannot get basic surgical care. So these are the people we see virtually every day when we're on the ground. The procedures that are needed annually, the lack of surgical anesthesia, obstetric care, and then the preventable deaths. And then the issue of shortage of clinicians, particularly in sub-Saharan Africa, which represents a large amount of the surgical need. 27% of the global surgery burden, but we're only seeing 1 to 2% of surgeons. For example, on the plateau, where I am in Nigeria, there are 6 orthopedic surgeons serving 3 million people, and they're not spread out there at the center of town in just one hospital. And then issues of practical skills, leadership needs, shortage of facilities, etc. But to really contextualize it, because I think that the greatest need that I have seen is actually access, not just on the part of the patient, but on the part of those of us that are trying to get into the global surgery sphere and then create some change. And what do I mean by the problem of access? I'm talking of access to training for surgeons that are coming from LMICs. The issue of surgical education is, we have the problems of conceptual barriers to training because of the relative virginity of global surgery as a field. Many of us from LMIC stumbled into it. I remember my last year of the university, I just drew a map of Africa and I wrote under it community medicine or public health, general surgery. I put a question mark and I wrote literally, I don't know with which I will reach my world. And so those conceptual problems, because many of us don't understand what the issues are, those conceptual problems are overcome. I've been able to overcome them by involvement in programs like the program Global Surgery and Social Change that address that for me personally. Then locational barriers to training. There are no local global surgery tracks or courses. You have to travel out of West Africa, for instance, to access effective global surgery training. Recently, the West African College of Surgeons introduced rural surgery posting. And this is an acknowledgement of global surgery, but there's a lot more that needs to be done. Idealistic limitations to training, things like funding barriers and funding challenges. I've lost opportunities to do 2 masters in public health due to funding challenges. I looked at a third and did not bother to apply because I saw a huge, like 25 million naira in fees. You see, and spent some time looking for grants, and then we kept seeing HIC citizenship as a prominent recurring requirement for many. We can't blame working citizens for prioritizing their citizens, but for me, mentorship solved the issue, and so a lack of contextualization is perhaps the other thing that seems to be a barrier to training. But the decolonizing global health movement has begun to champion this for us from several fronts, so that from an LMIC perspective, we're not forced to see global surgery as something that HICs are doing for LMICs. So for me, I think that's perhaps one of the greatest challenges I've seen, and that will help, solving that will help to address the issues of surgeon, anesthesia, and obstetrician density. Thank you.
Thank you, Barnabas.
Yes.
Micheline?
Yeah, ready. So I wanted to introduce our next speaker, Dr. Fabiola Castedo. Dr. Castedo is from Bolivia and has actively worked on global health through international institutions such as International Federation of Medical Students Association, World Vision, and others. She has been also a national president of IFMSA Bolivia, and currently she is working as a resident doctor of neonatology at the Centro Hospitalario Pereira Rosell Health Center of National Reference for Maternal, Neonatal, and Pediatric Care in Uruguay. She is National Junior Representative for Uruguay at the Global Ped Search, a multi-center research collaboration of surgeon, anesthetist, and allied health professionals caring for neonates and children requiring surgery across the globe. And she's also a member of Global Surgery Working Group at the Junior Doctors Network of World Medical Association, and is an active member of Neonatal Surgical Attendance Work Group at her local hospital center. So Fabiola, as you work with the smallest human beings, I would be curious what got you hooked up into global surgery?
Thank you so much, Michelina, for the presentation, and I'm really honored to be part of this panel. Actually, to respond to this question, I would like you to take you to a little journal of one of my experience with 2 neonatal patients. In 2018, I started my program residency in neonatology here in Uruguay, and it was absolutely overpassed all my expectations. And at a night shift, I received a newborn with a gastroschisis without a prenatal diagnosis. So as many of you can imagine, that was very shocking for the family, and everyone was at that delivery room. So we provide all the assistance as our protocol guide us to this pathology, to the newborn, while simultaneously our supervisor was calling to the pediatric surgery service to inform about the patient. There were exactly 20 minutes after the birth when I saw all the surgery in pediatric surgery team getting into the room. We were ending to make the silo, and they evaluate the patient, and they went talk to with the family, and they tell, I can perfectly remember the words. They say to the parents, your baby needs surgery. Into 2 hours, we are getting to the operation room to resolve your baby's condition. 15 minutes later, the neonatal palliative care team was also getting into the delivery room and giving support to the family and providing them clear information. And one of the things that they said to the family was, you don't have to worry about any cost. Health system is going to cover everything. So please don't worry about that. So that was pretty perfect, a pretty perfect answer from the health system. And then 5 months later, during my vacations, I was in my hometown in Bolivia. I was visiting the maternity of reference in my city, and the director of the hospital received a call. And there was a call from another city that is 356 kilometers from mine. And the doctor in the other side was telling us that they had a newborn with a gastroschisis as well, and without a prenatal diagnosis. But they don't have the capacity to resolve it at their hospital. So they have to transfer the patients to our city. And the transference is the only way by plane. So they were discussing which are the possibilities. And in Bolivia, we have air transfers of patients for indigenous communities. And this possibility was enabled for this family since they were not from indigenous community. So the have for the transference in the first instance. And once the baby get into my city, as well, the hospital, the public hospital doesn't have the capacity to receive the patients since the city was collapsed. So we had to connect that patient with a private service, and there was not a safety that after the government or the public health will reimburse the family with the cost. So two pretty different situations, and I felt at that moment quite of shocked on to see two newborns with the same conditions and with the same diagnosis, but with very different possibilities of access to surgical care. So I think this, in retrospectively, make me help me and actually to understand that accessibility is more than just distance. It has to be, as Lancet Commission on Global Surgery referred, timely care, the surgical capacity of hospital centers to resolve it, and the safety of surgical and anesthesia care, and the affordability. I think in Latin America, many factors contribute to unequal access to surgical services, but the main the main obstacle that many of us have to confront is poverty. So it stands into the way the cases to basic. So I think that was the personal experience that make me look to make a difference, as probably many of past FMSA members could react to this situation. I asked myself what I can do, and I found at the GDA, at the global surgery path, a way and an open door to work on this file. And thank you so much for that opportunity.
Thank you so much, Fabiola. And both of you, Barnabas and Fabiola, mentioned the context as a challenge, and I hope that in the future, throughout this webinar, we would be able to unpack a little bit and touch base on the important points that you guys already mentioned. Wilgens, over to you.
Thanks, Michaela. And two things in the center of global surgery is advocacy and the youth, the future of the OR. And we have with you a champion of both. Our next panelist is Dr. Micheline Dreza. He is a legend doctor and a current MPH MBA dual degree student at the Johns Hopkins Bloomberg School of Health and Carey Business School. He is a fellow Paul Farmer Global Surgery Research Associate at the program Global Surgery and Social Change at Harvard Medical School. Dominic has introduced the concept of global cardiac surgery to literature and established the Global Cardiac Surgery Organization to advocate for the nearly 6 billion people worldwide without access to cardiac surgery care. Dominic is a co-founder, immediate past chair, and current trustee of Incision, which is the world's largest global surgery training organization. He has published over 70 peer-reviewed articles in global surgery and cardiac surgery. Welcome, Dominic. It's a true pleasure to have you with us today. And my question for you, you've been working in advocacy within global surgery. How are you getting involved with policy development and advocacy for both at local and regional and on national level?
Yeah, thank you so much, John, for the kind introduction and also for the organizers for inviting me. It's a great pleasure to be here. I think this is a very core component of what we do and what we talk about when we speak about global surgery, being the advocacy and the policy aspect. Obviously, we talk a lot about the differences or the disparities in terms of access to care globally, and a lot of that is driven by a lack of attention from both the top-down and the bottom-up processes that actually address these disparities with a focus on surgical obstetric and anesthesia care. 2015, as I'm sure that most people on this call will recall or have heard of, was kind of a pivotal year for global surgery, with both not only the Lancet Commission tackling it from an academic perspective, really addressing what the existing gaps are in terms of global access to surgical care, but also at the level of the WHO, unanimously passing the resolution WHA 68.15 on access to surgical and anesthesia care and the role of those as a component of universal health coverage. Now, as important as this resolution was in 2015, which really drew attention towards the role of SOA or surgical obstetric and anesthesia care within global health, eventually these policies, which are just a paper document, had also be implemented at the regional, at the national, and at the local level as well. Now, as a co-founder and a former member, former co-chair of Incision as well, one of the biggest aspects that we try to push as a student and young doctor organization within global surgery is also recognizing the role of the future of the OR within that, within influencing and supporting policies and how they are being developed, but also advocating and spreading awareness about the inconsistencies within the attention within different global health silos or different global health aspects, and really moving towards a holistic health systems approach that recognizes the integral part that surgical care plays within that. And so over the years, since 2015 or 2020 now, so over the past 5 years, a lot has changed, where moving from the resolution itself with an increasing attention on kind of the academic and research level for mapping these gaps in access to surgical care. Various countries have also moved towards the processes of national surgical obstetric and anesthesia plans, or NSOPs abbreviated. And so now in this moment in time, several dozens of countries are currently developing these plans, recognizing that SOA care has a crucial role to play in health systems around the world, regardless of what income group the country is from. and how that can be strengthened and scaled moving forward to actually be embedded within the National Health Plan, National Health System. Now, within that, we also recognize the fact that a lot of these plans, the resolution itself at the WHO, but also these national surgical plans, that all of these have long-term implications. These are strategic plans that span 2, 5, even 10 years. And eventually these will have implications for decades to come in terms of access to care. At the start, however, there was little inclusion of medical students, of residents, of young doctors in these processes at the health policy level, which is very unfortunate because if we look at when these plans are being developed and at the point where we're actually trying to come to the goals of the Lancet Commission of the Sustainable Development Goals and even far beyond that, we're really talking about the stakeholders at that time. The stakeholders at that time are a lot of the people who are in this webinar, is the future of the OR. And it wouldn't make much sense to really talk about the future. It wouldn't really make sense about strengthening future health systems if we're not listening to the future of the OR as well. And so I think in terms of, not just in terms of Incision's involvement, but really any kind of student, young doctor resident effort over the past year, whether as a group or individually, as many of the champions on this call have shown as well, is really critical to making sure that not only are these plans that we're developing inclusive, but they're also feasible and sustainable at the point of implementation as well.
Thanks, Dominic. Indeed, we need a global surgery to be sustainable, and global surgery can't be sustainable without involvement of the youth and the future of the world. Karina, I'm coming to you.
Sure, thank you so much. Oh my goodness, we are having the rock stars on the line, and I'm very glad to be introducing Purva Prabha Patil, who is a final year medical student at Kasturba Medical College, Manipur, India. As the president of Medical Student Association of India, she leads a network of over 20,000 Indian medical students with a grassroots impact at a community spanning across India. She is also the Southeast Asia Regional Liaison Lead at the Gender Equity Initiative in Global Surgery, and the youngest co-moderator of Health Information for All, which is a global health network collaborating with the WHO. Currently, she leads multiple grassroots initiatives and global surgery projects aimed at addressing barriers to accessing safe, affordable, and timely surgical care in her community. She's received several accolades, including Indian Health Professional Awards and Women of the Future Awards in recognition of her work. So Purva, I would be super interested to hear your story, your global surgery story.
Thanks so much for the kind introduction, and thank you so much for having me on the panel. I would say it's a pretty difficult task to be summarizing my story and summarizing why I started working with global surgery, but I'll try. So I have personal as well as professional experiences with barriers to accessing surgical care. And personally, so I live in this small town in India called Ratnagiri, which is on the west coast, and I live in a rather unconventional family. My mom's an independent single mother, so finances haven't been kind to us since the very beginning. And having grown in circumstances like these, I landed in a circumstance where I myself needed to have a surgery for a mass that I had in my lower limb when I was 17. And surprisingly, the biggest concern that we had at that point was not when to get operated or where to get operated, but was, do we have the finances to do this now? And I think that experience just stayed with me, and I didn't think how big of an impact it had on me until I really started working as a medical student and entered med school. And in India, especially, it's not very uncommon to hear stories of people literally being pushed into poverty because of how expensive and how unaffordable surgical care is, but at the same time, how necessary it is. And I've been exposed to health systems that do check the box in terms of having facilities or being able to perform certain procedures. But if a lot of us were to made, were to even imagine ourselves or our loved ones getting any sort of healthcare in facilities like that, it would be a nightmare. And with all of this in mind, it wasn't unnatural for me to find myself in global health and global surgery specifically. And that's on top of it, being a young person, being a young brown woman, and just how many barriers that brings along as a professional and also as a recipient of these services. I think it really just it was natural for me to start working in global surgery, and that's how I ended up here.
Thank you so much, Purva. Over to you, Elgins.
Thanks, Karina. So our next speaker is Dr. Alicia Abbas. She's a young doctor from Pakistan, and she works as a global surgery research associate at the Global Health Directorate and Health Network, Pakistan. She's passionate about global surgery, gender equity in surgery, and she used innovation and research to improve access to safe, timely, and affordable anesthesia and surgical care for all. She co-founded and currently chairs the Incision Global National Working Group in Pakistan, and she's one of the research leads at the Gender Equity Initiative in Global Surgery. Dr. Abbas, thanks for being with us this morning. We would like to hear your story and all you got involved into global surgery, and also how you use research in within your practice in global surgery.
Hi, good morning. Thank you so much for the kind introduction and the invitation. So I think my global surgery story goes back to when I was in medical school, and we were rotating through primary care, and we went to one of the outreach clinics that our medical school has. And I saw a young boy walk in. He was limping, and living in Pakistan, my first thought was that he may have poliomyelitis. He was a 14-year-old boy. And when we took his history and exam, and we proceeded to examination after obtaining informed consent, what we saw, that story I can never forget. According to their history, he had he had an unhealed wound because he suffered traumatic injury, but they were not able to seek care for that. But on top of that, unfortunately, his wound was infested with maggots. And my first thought really was that this is a tragedy. This is a tragedy for him to experience this. It's a tragedy for anybody in the world to ever experience this. He was a young boy who should be playing, who should be studying, working, should be doing all the other things that children his age are doing. But he wasn't getting to do that. So initially, the first thing some of my colleagues worked with are attending to make sure that the patient receives safe, unfortunately, it was not timely, surgical and nursing care at the teaching hospital with our medical college. And a few months later, I saw my patient walking on their own. Their wound was so much better than the way we had seen it before. And they were smiling. And really, I think we were fortunate to have crossed paths with that patient, because that opened our eyes to see how much more there is that needs to be done. Because, and the whole scenario made me very confused, because that patient lived about a 30-minute drive from some of the biggest hospitals in the city of Karachi. And there are a lot of big hospitals here. What made me confused was the fact that I had seen patients come from far away villages and towns, sometimes even neighboring countries, to receive care at our hospital. So basically that reiterated the fact that it's not just geography, it's not just poor road infrastructure, that one of my dear panelists also talked about before me, that it's not just about that. There's so many hidden barriers. There's cost, there's awareness, there's cultural barriers that exist that we need to break down in order to ensure that every patient will have access to care. We need to work on all these levels. And coming on to the second thing, as you mentioned, how we can use research for that. So I think research has a very strong role to play in building onto your advocacy efforts. So it was research that tells us that more people die of conditions that require surgery as compared to everybody who dies from HIV, malaria, and TB combined. It was research that told us and helped us advocate for children's surgery because authors were able to show that investing in children's surgery is cost effective. It was research that showed us that if you do invest in children's surgery, you are able to avert millions and millions of disability adjusted life years. So all of these things will help you talk to the person that you're trying to convince that you need to invest in this. You need to help us achieve this goal. And I think trainees and students, empowering them to be able to do these things is very helpful. I was very fortunate to have crossed paths with the mentors that I worked with, Dr. Sama, Dr. Bernard, Dr. Rice. So they really helped me because whenever we have a discussion and you put forward an idea, and if you're the junior most person in the room, but they really ask you, what do you think about this? How do you think we should take this forward? And then really echoing what Dominique just said, you can't sort of make decisions about the future without really involving the future of the OR. So just quickly to summarize, one of the things that we were able to do via our research efforts was to try to come up with a list of procedures for children's surgery. I'm sure everybody is aware of the bellwether procedures that we have for grown-ups, for adults. They don't apply to children. They don't apply to neonates. So you can't just use that as an excuse to not find an alternative. And the first time we tried, it failed. We changed our approach. We came up with a separate project. We wanted to do focus group discussions. And we realized very quickly that it would be very costly to try to get experts from all over the world in children's surgery at one place at one time. And we didn't have any funding for this project. So we decided to be innovative in our approach, and we moved everything from in-person to online. It was tricky. It was daunting at first because there could be electricity issues, there could be internet issues. Everybody was in different time zones, but we were able to make it work. Not once, not twice, but we were able to do it 4 times. And I think that really allowed us to engage with providers from low resource as well as high resource settings, and then get everybody's consensus. And then one of the interesting things about that was that I was able to talk to a group full of not just surgeons, but also pediatricians at a global child health conference, where we invited them to join our efforts in trying to promote the provision of children's surgery. Because especially in areas where there's a dearth of pediatric surgeons, Pakistan, for example, has 0.4 surgeons per million children. Malawi, for example, has 0.14 pediatric surgeons per million population. These statistics really tell you that you can't do this alone. Surgeons alone cannot do this. And so one of the things that we're trying to do back home is develop a project where we're working with the departments of neonatology to train our midwives, nurses, pediatricians, and neonatologists to identify congenital anomalies at birth. And what that does is that if you don't have a pediatric surgeon, our parents don't have to be worried. They don't have to be anxious about who they need to take their child to. Or if they do need to take their child to, then you can sort of work and remove that extra delay that's there. So I think once you've tried to remove all the barriers, whether that's political, that geographical, financial, and any other barrier that you can think of, that's when you can truly say that you've tried your best or your innovational solution didn't work. So that's basically my experience. Thank you.
Thank you so much, Alize. What a forward-looking panel. I mean, if that's the future of DOR, we are definitely in the safe hands. So I really can't wait for the discussions that we are going to have. Just before we jump into the discussion, I wanted to remind that all the wonderful attendees that we do have can ask questions. So don't hesitate to type your question in the Q&A. So let's switch gears, dear future of DOR, and let's address some of the elephants of the room, as many of you have already touched base on some of the challenges. So I just want to pick them and just think, like share what you guys are thinking about several things that are already mentioned. So starting with a definition, because a wise person once said that when you have a definition, it's a halfway success of actually unpacking the problem. So speaking about global surgery, I was wondering if some of you can address the definition itself. So how should we define a global surgery within the global health conversations?
Well, I think I can jump on to that.
Sure, go ahead.
So global surgery, I like to quote Jim Yong Kim. He said, surgery is an indivisible, indispensable part of healthcare. And so when we're talking of surgical conditions, things that potentially require suture, incision, excision, manipulation, etc., may or may not require, in fact, they include conditions that don't always require surgery. But when we talk about global surgery, we're talking of an area of study, an area of research and practice and advocacy that wants to improve health outcomes and achieve health equity for all people who need surgical and anesthesia care. But the emphasis is on underserved populations, on populations in crisis, and then it utilize a lot of cross-sectional and transnational approaches to synthesize population-based strategies, and its aim is to improve health and health equity for anybody who's affected by surgical conditions or have a need for surgical care. Now, I'm coming from an LMIC. I want to ask the question and answer what really is global, because when some people hear global surgery, they're thinking something that's going on really far away. Must a surgical crisis cross national boundaries or borders to be called global? The global in global surgery refers to the scope of the problem, not necessarily their location. So global surgery focuses on domestic health disparities, issues that cross national boundaries. For example, where the care of internally displaced persons, there are about maybe 2 weekly herdsmen terrorist attacks around here, and then they're displaced within their state, is as much a global surgery issue as traveling to give surgical care to refugee camps in Iraq. So global surgery is the work we're doing for more than 5 billion people who don't have access to safe and affordable surgical care. The work we're doing to make basic surgical care accessible to the more than 90% of people in low-income countries who don't have that care. The work we're doing for the 313 million operations that take place in the world, but only 6.5% take place in the poorest parts, poorest third of the world. And those are the people that need surgical care the most. You know, it's what we're doing for the one quarter of people who have that surgical procedure that and then enter into financial catastrophe as a result of seeking care. So what global surgery is doing is trying to address the many dimensions of this problem, including surgical skills, identifying barriers and strategies for overcoming them, advocacy, education, research, clinical care. And for a long while, you know, till today, and I stand to be corrected, in for example, the Nigerian surgical space, there's no significant local global surgical investment in most quarters. And the reason for this is many people think that surgery is expensive, it's not cost effective, it's not economically feasible, it takes a lot to do. And so we're focusing on things like TB, malaria, HIV, onchocerciasis, vaccination, maternal cares. But by the time we look closely, research has busted that myth. It is feasible, it is cost effective. And all this was catalyzed by the Commission, DCP, the movement, the WHO resolution, and global surgery. One range of interdisciplinary and multidisciplinary field within global cooperation with the flux between LMICs and HICs, and then a focus on both individuals and population and geographical reach, things that transcend national boundaries, yes, but even things that are within countries, and then the priority on access to health or health equity. So that's our focus, and really, I think that's the dimension, that's my perception, and that's what global surgery is about. Thank you.
Thank you so much, Barnabas. So many wise words. I think that it's also a challenge that all the global health, quote unquote, community is facing with regards to what is indeed global health. And I love what you said about, you know, learning from each other and using this transnational collaborations and the platforms that we have in order to address, you know, common troubles with regards to access to surgery. Anyone else would like to jump on this question?
I can jump in if that's okay.
Please go ahead, Tiva.
Perfect. So when I first came across the word global surgery, I was in the second year of my med school, and it just sounded very weird and new to me, and I thought I knew absolutely nothing about it. But having been around for a while, my understanding of global surgery has really shaped up from the experiences I've had around it. And in the words itself, it says global surgery. Surgery for everybody across the globe, regardless of their gender, regardless of their nationality, their socioeconomic status, their education, their religion, and any other differences that exist. And in that context, a very persisting thought that I always have is I've never met a single person that wanted to end up in a circumstance where they needed surgery. And I can almost bet that neither of us have. And as health professionals and as somebody who can really push decision makers who have the power to do that and who are very adequately and very well positioned to do that, the least we can do to help people in such circumstances is to make sure that the journey to recovery or even to palliative care is easy, and the financial status or any barriers that exist, be it language barriers, be it geographical barriers, be it any sort of barriers, should not come in the way of deciding how likely they're to get a cure or how likely they're to get a more comfortable journey to end. And having that said, I think it's also really important to talk about how we need more inclusion in global surgery. And when we say global, it should truly apply to the whole globe, as Barnabas also mentioned. But yeah, that is my understanding of global surgery. And I'm sure a lot of us in a lot of different contexts understand and prioritize certain barriers more than the others. And and global surgery is a way of finding how we can exchange these practices, how we can exchange this knowledge, and make sure nobody really nobody's in a position where their mortality or their morbidity is determined by where in the world they are or what they do for a living.
Now? Sorry. So thank you so much for the wise words. And I know that we were speaking a lot about challenges, but I want to switch gears into solutions. So I want to ask, and please feel free to jump in, probably running out of time, but I hope that we're going to hear some solutions. So the question is, what has been the biggest challenge in your global surgery career, and how have you addressed it or overcome it? And you only have 60 seconds because we're running out of time, and I'm gonna keep on counting, but I would love to hear some amazing solutions to all the challenges that you guys have been mentioning throughout this call already. Anyone would like to volunteer first? Hassan, maybe you.
Thank you. And I would like, I hope I can do this second, but I'll do my best. There is this story that I have seen. A young child has been hit by a small taxi, called it the charge. In the Indians and Pakistanis, so we charge a small taxi, so was hit by a young child, and she was, having respiratory distress and admitted to the hospital. It was late at night. There was the healthcare worker was not there at that time, and so I tried to help, but again, I saw the family decided to take back from the baby from the hospital to another private hospital, and I recognized that there is a big gap when it comes to emergency conditions. We don't have emergency hotline system like number to dial. Ambulances are very few. People they mostly reach at the hospitals when they are already dead or very late complications after injuries happen. So my biggest question was, how can you connect the healthcare workers in the universities, the community, the hospital together? And I was in the medical school, lots of assignments, lots of hospital ward rotations. So, and I tried to speak with the principal of the university. I said, can you accept to train paramedics He said yes, and I tried to communicate with King's College, which London, UK, who fully support our university. I said, can you guys help us with the curriculum of training paramedics? They accepted. I tried to find someone who funds, for some funding projects, and I found there is a winning project happening in Namibia, leading by a professor called Professor Hall from Cardiff University. So she said to me, I cannot deal with a 6-year medical student, a final year medical student. I want to speak with some of your government representatives. So I connected her with our ambassador in the UK. They have a meeting, and she paid a visit to Somaliland. And she connected with the Ministry of Health, the university, and everyone. And after that, we tried fundraising for the project. We fundraised money of $22,000, and we bought the first ambulance for the project. Again, we spoke with the telecommunication company to provide a hotline and build a dial number or a calling center in the hospital. And so the ambulance has reached us like a year ago. So the project is still happening slowly, but this was the biggest challenge that I came through while I am working on the medical school, doing assignments, trying to connect all of these different puzzles. So that was my biggest challenge, and I'm still working on it, developing a hotline center in that my university town where I was having my medical school. Thank you.
Thank you so much, Hassan, and all the doctors on the line and the medical students totally get how hard is it to be an activist throughout school and still keep on with all the assignments. So totally feel you, and you're definitely our hero. I would take one more person to talk about solution, and we're going to switch gears and speak a little bit more about the advocacy component of global surgery. So anyone who would like to share the solution? Alicia?
Yeah, I can take a very, very quick shot at this because
Go ahead, please.
I think there's another facet that's very interesting and important to talk about, especially in the context of use in global surgery. Very quickly, when some of my colleagues and I, we started the Pakistan National Working Group for Incision, and we sent out posts for people to join our team. What we noticed in the applications, unfortunately, was that there were a lot of them were from the bigger cities where we already have medical colleges, we already have a lot of opportunities, and we wanted to make sure that we were very diverse and inclusive in our team as a whole. And of course, that's a stepwise process, but we wanted that from the very beginning. So as a solution to that problem, what we did see in the applications was that there were some people who were representing whole regions and countries as the only people from that region. So we decided to introduce the concept of outreach members, in which those people are going to be responsible for, can take the lead in trying to create awareness about global surgery. And this was especially important because we'd like people who even may not know anything about global surgery at this stage to be able to learn about it and to tell this to other people. This idea is, of course, because we started this only a few months ago, so this is still in its infancy, but we're hoping that this is going to be a first step in trying to understand also the needs of students and trainees in those areas where this topic may not be talked about that much. So that's one of the things that I thought it's worth to share.
Thank you so much, Alize. So I heard inclusion of young health professionals, I heard addressing inequalities, and I heard thinking outside of the box. So that's definitely some tips for also the attendees on the line. Thank you so much. Over to you, Wilgens, to switch the gears a little bit of our discussion.
Thank you, and that has been awesome. Well, there's a question in the Q&A section, so I'm gonna direct it to Dominic, but anyone else feel free to jump in. So, Dominic, what do you think medical students and young professionals can contribute to current advocacy and policy efforts? I mean, this question is for Lotta, from Lotta in Sweden. Youth are often a progress voice. As an example, youth have been championing climate change and issues of social justice. What unique perspectives do you think youth can bring to global surge?
I think that's a great question in terms of kind of the role and the potential for students within the global surgery scene, whether we're talking about advocacy, policy, research, or any other approach to it. And I think that a lot of people on this call are kind of a testament of what the potential and the impact of students and young doctors in the field are. Um, Easy ways to get involved is simply connecting with local individuals who are already working on it. We have Kathy and Chia on the line, who are the current co-chairs of Incision. And Incision is currently vast around the world with national working groups in over 50 countries, members in almost half of the world's countries. And so there are people working on global surgery in different capacities all around the world, and especially also on the student and young doctor level. And that's an easy way to get involved. Secondly, is also simply connecting online. Obviously, Incision and everybody really during this pandemic is doing a lot of online work. And that's also a low threshold way to actually learn more about the field, seeking what opportunities there may be ahead for you to get involved remotely or through advocacy, or more in the distant future also in terms of policy work. And then I think thirdly, and that is really both in terms of the Incision National Working Groups, but also other young clinicians and students, et cetera, that have been involved, is that there is a big role for actually influencing policy change. A lot of the national working groups have been supporting local national surgical obstetric and anesthesia plan developments. We have Hassan here, who's trying to catalyze it in Somaliland. The group in Colombia, Incision Colombia, has been supporting stakeholder discussions at the local level, et cetera, et cetera. And there are many examples of that that are really showing that students are increasingly being listened to, but there's also an increasing potential for them to get involved. So I would say to those who are actually seeking opportunities to get involved, also aligned with what Elise mentioned earlier, is that there are so many people who are great mentors in the field, but are warm and welcoming in terms of getting students involved. And I think that's really the core strength of the global survey community, is that everybody has the same goal, the same target, and is always trying to get more and more people involved and more people to actually pass on and carry the torch forward.
Thank you, Dominic. Great insights. And we are out of time, so next question. COVID-19 is part of the highlights now and in the headlines. So COVID-19 is obviously affecting global surgery efforts and your experience daily into global surgery. So the next question is, how has COVID-19 affected your global surgery efforts, and how can SOE care and be related to pandemic response? Anyone?
Yeah, I can go for that one. I would say it's inevitably affected global surgery in a lot of ways, mostly negative, but then there's also silver linings to the dark cloud that we're standing beneath. There was a recent paper that just estimated what is the surgical load that's basically just standing still because of COVID-19. And within India itself, since the pandemic started and the lockdown was announced in March, up to the month of June, more than 500,000 surgeries, elective surgeries, were called off or are put on a standstill. And that includes a lot of surgeries that could potentially lead to devastating complications. So in terms of surgical care, COVID-19 has quickly emerged as one leading barrier, and needless to mention, with it comes more visible or more pronounced inequalities, just in terms of anything you can think of, leading to all the more difficult access to surgical care and services. Apart from that, in terms of just advocacy effort in global surgery, I think a lot of us had this year planned a certain way, but suddenly surgical residents and even residents from non-surgical specialties are all pushed into working for COVID-19. It's affecting their education, it's affecting their skill, and it could potentially also have a big impact on how their career progresses. So in terms of not only, if I had to put it that way, not only recipients of surgical care, but also the people delivering care, COVID-19 has emerged as a leading barrier. But more importantly, in terms of how it's affected us, I think it's affected us for good also, to realize how important global surgery is and how it's always been somewhere around, and it's somehow gotten a spotlight, and now we know that this is a real problem, and this exists not only in LMICs but in countries across the world. And now we also have a motivated workforce that's inclined towards working towards this. So I think COVID-19 has shot two arrows in two different directions.
Thanks, Purva.
So many wise words.
Anyone else?
And I
like to say,
sorry, I wanted to just jump in because we are really running out of time. And I still, my dear future of DOR, I still want to give you one last message to share with our amazing participants. So should we give them a small words of wisdom, your final message before we finish this webinar? I'm gonna ask Barnabas, what is your last word for this webinar?
I just have something to say to a lot of the young people in LMICs that are trying to get involved in global surgery. I think that there's a Yoruba proverb that says that human beings are what you use to cover yourself. The issue of mentorship is extreme. Almost every one of the problems that may be hindrances or barriers to your pushing into the field and then doing what is in your heart can be overcome by mentorship, by partnerships, by connection. So you just have to stretch yourself and reach beyond where you are. Look at the Human Resources for Health program in Rwanda, the place where they had the lowest life expectancy in the world today, houses the University of Global Health Equity. A lot of things have changed because of the issue of pairing, mentorship, training. So for me, some of the fun things that you think funding is a barrier, location is a barrier for, by the time you begin to connect with the right people, and they're all over the global surgery space, you just need to push yourself up. So that's the thought that I have.
Thank you so much, Barnabas. Alize, would you like to go next?
Sure, thank you. I think what I really want to put out there is, if we try to achieve equity and justice in global surgery, we must remember that compassion and kindness must lie at the center of it. And that goes for our patients, that goes for our colleagues, our peers, our mentors, mentees, everybody. So once we have that in mind, I'm sure we can work towards developing mutually beneficial relationships and partnerships. And I'd just like to urge everybody who's on this call, if you haven't started yet, it's not too late, you can still start. And if you think what you're doing is too small, that's never true. And I think every effort that you make will count. So do not give up, even if you do face challenges. And lastly, I do want to say that we must prioritize children in our effort to achieve surgery for all, because most importantly, we were all children once, and somebody made sure that we had access to opportunities and education and health. So children cannot advocate for themselves, and we must advocate for them. Thank you.
Thank you. So, Asan, what will be your take-out message for our future for the future of the order?
I would like to agree with Barnabas. Mentorship is very great, and I'd like to thank for Dominic, who was very close, and with the help of him, we organized it in Section Somaliland, and that's where the whole connections have started. So I agree with Barnabas about the mentorship and connections and partnerships. We grow through partnerships. The second thing I would like to share is try to work locally, not like directly taking things from the international and trying to make it work in your country. It might not fit. So now here we see people have no access with medical care, and we try to start more pilot-free clinics, organizing other doctors and going outside outreaches and giving back to the community. So try to be innovative, creative locally, and reaching out to your community. That's the most important thing. Thank you.
Thank you, Hassan. And there's this kind of a motto in global health we like to use: think global, but act local. Thank you. So, Bova, do you have a last message for our public today?
Yes. So I'm sure this has been happening for a lot of people, but if I had to give one message, and I'm also being honest to myself, there will be a lot of challenges and a lot of barriers in the way of whatever you're doing. And change never comes in easy, and it never will. And you have to keep finding ways of sticking to your journey and sticking to your destination, and make sure nobody or nothing comes in between of it. If my mother always says that if there's one door that's closed, you'll find another. There's always another one. It's just a matter of you finding it. And that applies to a global surgery context as well. And for the medical students and young professionals watching, I would say that a lot of us have siloed ourselves in academic grades, assignments, and things that are important, but at the same time not as important as really caring for our communities and understanding that the problems that they bring to us in the clinic are just problems they face on the surface. And we're only going to be doing justice to them once we start looking beyond them and see what circumstances they live in, or what circumstances their families live in. And that's how we're going to keep moving forward. And specifically for girls and non-binary people watching right now, I have always felt like I've never found mentors that have journeys like me or that look like me. And I know that it's very disappointing to be in that place, but know that you have the potential of being that mentor that you did not have. And everything you do, it's not just you doing it as a single person, but how you take this forward and what journey you make for yourself will also inspire a lot of people watching you from the behind that you probably don't see right now. And I'll just end my closing remark with something that really drives me. And it's a very sad day for humanity in general, with the loss of the person that said this quote. And the quote goes, "Fight for the things that you care about, but do it in a way that it will lead others to join you." And that quote is by RBG, if few of you did not guess. So I'll leave you with that. Thank you.
Thank you so much, Purva. And I love the quote that you said, that we have all an opportunity to be mentors that we didn't have. And it's indeed the future, facing opportunity that this panel is definitely bringing. And I'm so happy. Fabiola, any wise words from Uruguay for us?
Thank you so much. I think pretty good goals have been set up between our interventions, and particularly from my side, non-surgical specialization in this point, I would like to highlight a point for this global surgery objective and commitment. I personally believe that global surgery is not just a surgical responsibility. It involves all of us. And if we can read in so many texts that say that if surgery is the objective stepchild of global health, then pediatric surgery is the child not yet born. I think that phrase really hits me, and it's not really motivating, but it can wake up us to start advocacy for getting neonatal and pediatric surgery for our populations. And neonatology in the last years, from a point of view and as data says, have progressed on improving the life expectancy of prematures and newborns with congenital malformations. But we can go further if we don't have a surgical anesthesia care for our babies and or new generations. and it has a really huge impact in economic and, social into our countries. So I strongly believe that we as society and part of the health workers need to reset our minds and look into the surgery, stop looking to the surgery like the luxury item into health. It's basic needed, we need to have and start growing up like a new generation with a holistic view of health, and including surgery as a part of our co-workers, and that with the specific point to improve quality life for our patients. Every one of us enjoy when we have good outcomes with our patients, and that only will be a reality for our nation and regional health if we work together. So I think that the words that was said before, surgery is an indivisible and indispensable part of healthcare. It's a reality, and we need to make that a reality for all our countries and regions. Thank you so much.
Thank you so much, Fabiola. Dominic, any last words for us?
Sure. I'll keep it brief, and I'll keep it mostly to kind of the lowest hanging fruit, and that would be to empower everybody to actually speak up. If everybody would tell somebody who doesn't know about global surgery or the global inequities in terms of access to surgical care, and they go on to tell somebody else, and they go on to tell somebody else, we're quickly around the world. As part of that is also to recognize that all of what we are doing is not siloed in terms of only those who have an interest in surgery, obstetrics, anesthesia, etc. But all of this has a commonality with so many parts of the health system. All of this is health system strengthening, as opposed to only looking what happens within an OR or what happens within a specialized area where we're providing surgical, obstetric, and anesthesia care. And as long as we recognize that, we can also push the barrier where people see us just as a surgeons, obstetricians, anesthesiologists, but see us as people who are actually trying to strengthen the entire health system.
I think that if someone needed some inspiration on Saturday afternoon or morning or evening, they definitely had it from over an hour of an exciting discussion. So thank you from my side. Wilgens, over to you.
So yes, thanks everyone for joining. Such inspiring quotes and takeaway from this session. You've been amazing. And as Micheline said in the beginning, with you and all our attendees, we are sure that the future of the OR is in great hands. Thank you again.
Have any last final words for us as well?
I'm just gonna close it off. Thank you so much, everyone. I mean, I know a lot of you, just from working and from seeing you around before COVID. Hopefully, we'll see you soon after. And I felt so inspired, even more inspired. So I hope that everyone who attended felt the same. It seems like we got a great crowd here too. Just to everyone, all the attendees, we're going to be sending out a final kind of feedback form. Please feel free to add any other questions that you have there. We're going to try to do our best after this even to reach out and answer questions and help to connect. But that form will also have our websites for the organizations that we're hosting this. A lot of people asked how you can get involved. Incision, PGSSC, the WMA all have ways you can get involved in these. So, so please take a look at those websites too. And thank you so much to everyone, to all our panelists, our awesome moderators, and everyone for attending. Enjoy the rest of your weekend.